You know that feeling when your heart does a little flutter, maybe after too much coffee, or when something startles you?
Yeah, that little skip.
Exactly. Well, today we're diving into something kind of related, but definitely more complex.
Mm-hmm.
Atrial fibrillation and atrial flutter in our pets, specifically dogs and cats.
Right. We're working from a pretty detailed veterinary text here, and the plan is to, unpack what these conditions actually are for dogs and cats.
Okay.
We'll look at how they show up, what's going on inside, and really pull out the key takeaways without hopefully getting lost in the medical jargon.
Sounds good. So atrial fibrillation and atrial flutter in pets.
Yeah, it sounds technical, but let's try and find the really interesting bits, those aha moments. Where should we start? Maybe just defining them?
Good place to start. So atrial fibrillation, AFib for short, sometimes is basically a really fast and crucially an irregular heartbeat. It starts up in the atria, the top chambers of the heart.
Irregular.
All
Okay.
right.
Yeah, it's chaotic. And what's interesting is we generally see two forms. There's primary AFib, which is actually pretty rare. You see it mostly in large dogs that don't seem to have any other heart problems.
Huh. So their heart is otherwise okay, but the electrical system just goes haywire on its own.
Seems like it, yeah. Then there's secondary AFib, and that's much more common. Like the name suggests, it's secondary to something else, usually existing heart disease. We see that in both dogs and cats.
Okay, so primary is rare, maybe just an electrical thing in big dogs. Secondary is common, linked to other heart issues. Got it.
Yeah.
And atrial flutter, how does that fit in?
Atrial flutter is similar, but usually the atrial rate isn't quite as astronomically fast as an AFib. And the big thing on an ECG, that heart tracing, is that flutter often creates this very distinctive sawtoothed pattern in the baseline.
Sawtooth waves. Okay, that sounds like something you could spot. So ECGs, those give us a direct look at the heart's electrical signals, right?
Right.
What do they tell us specifically about flutter versus fibrillation?
Oh, the ECG is absolutely key. For atrial flutter, you typically see a regular fast rhythm in the atria, maybe 300, 400 beats per minute. And yeah, that sawtooth baseline is the giveaway.
Regular but fast in the atria.
Okay. Now, how the ventricles, the lower chambers, respond, that can vary. It might be regular, it might be irregular. It all depends on how the signals get through the AV node. Think of it like a gatekeeper between the upper and lower chamber.
Very gatekeeper, right?
So you might see something like a 2.1 conduction where every second atrial beat gets through. In that case, the ventricle rhythm would be regular, just at half the atrial speed.
So flutter has some organization, even if it's super fast.
Mm.
What about secondary AFib on the ECG? Is it just messy?
Pretty much. In secondary AFib, those normal P waves, the little bumps showing the atria contracting, normally they're gone. Instead, you might see just a flat line or maybe these tiny irregular F waves, F for fibrillation.
And no key waves, just F waves.
Okay. Sometimes these F waves can look a bit like P waves, which can be confusing, but the key is the ventricular response. It's fast, like 180 to 240 beats per minute in dogs, maybe over 220 in cats, and totally irregular chaos.
Wow, that's fast and chaotic.
But interestingly, the QRS complex is the big spike showing the ventricles contracting usually look normal in shape. So the main problem signal is coming from the disorganized atria.
And primary AFib, how does that look different on the ECG if the heart structure is mostly okay?
Electrically, it looks very similar to secondary AFib. You still have the missing P waves and those irregular F waves. The main difference is usually the rate. In primary AFib, the ventricular rate, so the overall heart rate you'd feel or hear, is often within the normal range, or maybe just slightly elevated.
So top chambers are still chaotic, but the bottom chambers are keeping a more reasonable pace.
Exactly. The AV node is filtering more effectively, perhaps, or the underlying drive isn't quite as intense.
Okay, that makes sense. So let's dig into the why behind this. What's actually going wrong in the heart muscle or its electrical system to cause AFib or flutter? The pathophysiology.
Right. For atrial fibrillation, the idea is that there isn't just one signal source anymore. Instead, you get lots of tiny, chaotic electrical circuits, they call them reentrant pathways, swirling around in the atrial walls.
Like little short circuits everywhere.
Kind of, yeah. It leads to incredibly rapid firing. The text says over 500 depolarizations a minute, but it's completely disorganized. So the atria aren't really contracting effectively anymore. They're just sort of quivering.
Wow, 500 plus. Okay.
And that AV node, the gatekeeper, it gets bombarded with all these signals. It tries to block a lot of them, but some get through randomly, which is what causes that fast, irregular rhythm in the ventricles.
So electrical storm in the atria, and the AV node is doing damage control, but it's overwhelmed.
That's a good way to put it. Now, atrial flutter is thought to be a bit different. It's more likely to come from a single, larger reentrant circuit in the atria, so it's still a loop, but it's more organized.
One bigger loop instead of lots of tiny ones.
Exactly. And this loop fires regularly, stimulating the AD node. But if that atrial rate in flutter gets fast enough, faster than the AV node can handle or recover between signals, then the node starts blocking some beats. Not because it's diseased, necessarily, but just because it's being hit too frequently. We call that a functional second-degree AV block.
Functional block. So it's not damaged, just overloaded by the speed.
Precisely. The system just can't keep up with the demand from the fast atrial rhythm.
Okay. Now, these electrical problems up in the atria, they must have knock-on effects, right?
Right.
What other parts of the body, or specifically the cardiovascular system, feel the impact?
Oh, absolutely. The biggest impact is on the heart's function itself. When you lose that coordinated atrial contraction, the atrial kick that helps top off the ventricles before they pump, you lose some efficiency.
Right, that extra little push of blood.
Yeah. So the stroke volume, the amount of blood pumped with each beat, goes down. And if the heart rate is also really high, the ventricles don't have enough time to fill properly between beats, so cardiac output, the total blood pumped per minute, can drop significantly.
Less blood getting out to the body.
And if that fast heart rate persists for a long time, the heart muscle itself can start to weaken just from being overworked. That's called tachycardia-induced myocardial failure.
Okay, so it's a double whammy, less efficient pumping, and potential damage to the heart muscle over time. That sounds serious. Who tends to get these conditions? Are certain pets more at risk?
Well, we definitely see both atrial fibrillation and flutter in both dogs and cats. The interesting thing, as we mentioned, is primary AFib. That really does seem to have a predilection for large and even giant breed dogs.
Like the really big guys.
Yeah, think Irish Wolfhounds, Great Danes, breeds like that. For secondary AFib and flutter, it's more linked to the underlying heart disease, which can affect any breed or cats.
And does the source mention anything about, like, average age or if males or females are more affected?
You know, it's interesting. The text we're looking at doesn't actually specify a mean age range or sex predilection. That's perhaps an area where more data could be gathered, or maybe it just varies too much depending on the underlying cause.
Okay. So, big dogs for primary, others depend on the heart disease. Now, for an owner at home, what might they actually see? What are the clues or signs that their pet might have AFib or flutter?
That's a really important question. Often the signs are actually related more to the underlying heart disease, or if they have congestive heart failure, CHF, rather than the arrhythmia itself.
So things like coughing or breathing problems.
Exactly. Coughing, shortness of breath, maybe getting tired easily. But sometimes an animal that seems stable with their heart condition might suddenly get worse when AFib or flutter kicks in.
Like a sudden decline.
Yeah. But then you have primary AFib, and those dogs, they might have no signs at all, or maybe just, they can't run quite as far as they used to, some mild exercise intolerance. It can be quite subtle.
So it runs the gamut from no signs to severe signs. What about specific things an owner might tell their vet? Historical findings.
They might report, coughing, difficulty breathing, maybe rapid breathing tachypnea. Exercise intolerance is a big one. Sometimes, though rarely, even fainting or syncope can happen. But again, worth repeating, with primary AFib, often the history is unremarkable. They seem fine.
Okay. And then when the vet examines the pet, what are the telltale physical exam findings? You mentioned the ECG, but what about just listening or feeling the pulse?
Oh, listening to the heart auscultation is often very revealing, especially for AFib. The rhythm is typically chaotic, erratic. There's this classic, very descriptive phrase vets use. It sounds like tennis shoes in a dryer.
Tennis shoes in a dryer. I can almost hear that. That's chaotic.
It really is. Just totally irregular tumbling sounds. And the intensity of the heart sounds can vary too. The first heart sound might be loud, then soft. The second heart sound might even be missing on some beats if the ventricle didn't pump enough blood to open the aortic or pulmonic mouth properly.
Variable sounds, missing sounds.
Yeah. And you might sometimes hear extra sounds, like a third heart sound. Then feeling the pulse, usually in the leg, is also key. You'll often find pulse deficit.
Pulse deficits, meaning?
Meaning you hear a heartbeat with the stethoscope, but you don't feel a corresponding pulse wave in the artery. That happens because some of those heartbeats are too weak to generate a palpable pulse.
Okay, so beat, but only pulse, maybe.
Exactly. And the strength of the pulses you do feel can be really variable. Too strong, then weak, then strong. And of course, if the pet has congestive heart failure, you might see those signs too: the cough, the difficulty breathing, maybe even bluish gums, cyanosis.
Wow, okay. That tennis shoes in a dryer description really paints a picture. So we know what it is and how it might present. What actually causes it? What are the underlying triggers or diseases?
There's a list of potential culprits. Chronic valvular disease is a big one, especially in older, smaller dogs, that leaky valve disease.
Mitral valve disease.
Often, yes. Also, cardiomyopathy, which is disease of the heart muscle itself, dilated cardiomyopathy in large dogs, hypertrophic cardiomyopathy, often in cats, congenital heart defects, things they're born with, can also lead to it.
Okay, so mostly acquired heart problems, but sometimes congenital.
Right. Also, digoxin toxicity. Digoxin is a heart medication, but too much can actually cause arrhythmias like this. And sometimes we just don't know. It's labeled idiopathic.
Oh, and for atrial flutter specifically, something called ventricular pre-excitation, which is like an extra electrical pathway in the heart, is sometimes implicated.
So quite a few potential roads lead to AFib or flutter. How does a vet definitively sort this out, especially if other rhythm problems can look similar? What's the diagnostic process? Good point. Diagnosis involves putting pieces together. First is considering the differential diagnoses. What else could it be? Things like very frequent atrial premature beats, or maybe a different type of fast atrial rhythm called supraventricular tachycardia that has some AV block, or even something called multifocal atrial tachycardia. They can sometimes mimic the irregularity.
So ruling other things out first.
Exactly. Then imaging is crucial. Chest x-rays, radiography, and especially an echocardiogram, an ultrasound of the heart. These help identify the type and severity of any underlying heart disease.
Like looking for that enlarged left atrium you mentioned.
Yes, moderate to severe left atrial enlargement is a very common finding in secondary AFib or flutter. It reflects the pressure and volume overload the atrium has been under.
But in primary AFib, the imaging might be normal.
Mostly normal, yeah. Sometimes you might see some mild left atrial enlargement, maybe just as a consequence of the AFib rather than the cause. But generally, the heart structure looks surprisingly okay in primary cases.
Okay. Are there other specific procedures? You mentioned the ECG.
Yes, and beyond just a quick ECG strip in the clinic, a 24-hour Holter monitor is often really, really helpful.
That's the one they wear home.
Exactly. It's a portable ECG that records every single heartbeat for usually 24 hours. This tells us if the arrhythmia is there constantly chronic or if it's coming and going paroxysmal. And that difference is critical for deciding on the best treatment approach.
Right. You need to know if it's an all-the-time problem or an intermittent one. Makes sense. Okay, so let's move on to treatment. Once it's diagnosed, what's the general strategy?
Well, it depends quite a bit on whether it's primary or secondary and how fast the ventricular rate is. For the more common scenario, secondary AFib with a fast ventricular rate, the main goal is usually not necessarily to get back to a normal rhythm, but to slow that ventricular rate down.
Rate control, not rhythm control.
Often, yes. Trying to convert back to a normal sinus rhythm, either with drugs or electricity, is often unsuccessful, or the normal rhythm just doesn't stick around for long, especially if there's significant underlying heart disease in that big left atrium. The conditions that caused it are still there, you know?
Okay, so managing the speed is key in those cases.
Uh-huh.
What about primary AFib, where the heart structure is better?
There, the conversation might be different. Electrical cardioversion, that controlled shock to reset the rhythm, might be considered, especially if the heart disease is minimal.
Is that commonly done?
It's an option, requires anesthesia and specialized care. But the text notes that even here, success rates are lower and recurrence is higher if the AFib has been going on for more than, say, 4 months. In those longer-standing primary cases, rate control might still end up being the preferred strategy.
Interesting. So even in the better scenario, getting back to normal rhythm can be tough if it's been there a while.
Yeah.
You mentioned electrical cardioversion. How does that work?
Yeah, it involves delivering a synchronized electrical shock across the chest using paddles or pads. The energy level, measured in joules per kilogram of body weight, is carefully chosen and might need to be increased if the first attempt doesn't work. There are different types of defibrillators used monophasic and biphasic, which require different starting energy levels.
Okay. And for atrial flutter, is the goal conversion or rate control?
For flutter, conversion back to a normal rhythm is sometimes more achievable than with AFib. This might be attempted with specific antiarrhythmic drugs, electrical cardioversion, or even, in some specialized settings, something called rapid atrial pacing.
Got it. What about general care beyond specific drugs or procedures, things like nursing care, activity, diet?
Yeah, they definitely play a role, especially if there's congestive heart failure involved. Standard CHF supportive care is important, managing fluid buildup, etc. Activity usually needs to be restricted, at least initially, until that fast heart rate is under better control.
Keep them quiet for a bit.
Right. And diet-wise, if CHF is present, a mild to moderate sodium restriction is often recommended, similar to other heart patients.
Okay. So for pet owners navigating this, what's the most crucial thing for them to understand? What's the key message?
I think the biggest thing, especially for secondary AFib and flutter, is understanding that it's usually a sign of pretty significant underlying heart disease. The therapy goal, therefore, is primarily about controlling the heart rate to improve quality of life and manage symptoms. Getting back to a perfectly normal rhythm long-term is, unfortunately, often unlikely in these pets.
Managing expectations is important then. Focus on quality of life.
Absolutely.
So let's talk medications. What are the go-to drugs for slowing that heart rate down in AFib?
The main players work by slowing down conduction through that AD node, the gatekeeper. We use drugs like digoxin, beta-adrenergic blockers, esmolol might be used intravenously initially, others like atenolol or propranolol orally, and calcium channel blockers, with diltiazem being a common one.
Digoxin, beta blockers, calcium channel blockers.
Okay. In dogs, the target rate we often aim for with these meds is somewhere in the 140 to 160 beats per minute range. Still fast, maybe, but much better than over 200.
A more manageable fast. And for atrial flutter, if you were trying for rhythm control, what drugs might be used?
For flutter, drugs that target the actual reentrant circuit in the atria might be tried. Sotalol, which has both beta blocker and other antiarrhythmic effects, is one. Amiodarone or procainamide are other options sometimes considered.
Okay. Are there specific drug choices or doses that differ between dogs and cats?
Yes, there definitely are species specifics. In dogs, digoxin is commonly used orally for long-term management. Sometimes they do a rapid digitalization loading dose over the first day or so to get levels up faster. Diltiazem is also very common in dogs, often started at a certain dose and then increased based on how the heart rate responds. But again, the text emphasizes conversion back to normal rhythm with drugs alone is usually unsuccessful for AFib in dogs.
So focus on rate control meds for dogs usually. What about cats?
In cats, diltiazem and the beta blocker atenolol are often considered first-line choices for rate control. Digoxin might be added if the rate isn't controlled well enough with one or both of those, or if there's evidence the heart muscle itself isn't pumping strongly myocardial failure. Specific dosages are, of course, critical and based on the individual cat.
Diltiazem and atenolol, first for cats. Maybe add digoxin. Got it.
Are there situations where these drugs shouldn't be used? Contraindications?
Big ones, yes. Digoxin, diltiazem, beta blockers like propranolol and atenolol. None of these should generally be used if the pet already has significant AV block, meaning signals are already struggling to get from the atria to the ventricles. Using these drugs could make the block worse.
Okay, don't slow down more if it's already too slow sometimes.
Exactly. And combining calcium channel blockers like diltiazem with beta blockers needs to be done very cautiously, if at all, because together they can slow the heart rate too much or depress heart muscle function.
Use with caution. Any other precautions? Well, both calcium channel blockers and beta blockers need cautious use if the pet already has significant myocardial failure, weak heart muscle, because these drugs can sometimes reduce contractility further. Also, an older drug, quinidine, sometimes used historically for conversion attempts, carries risks of toxicity at high doses and needs careful monitoring.
Okay, and drug interactions. Anything major to watch for?
One specific interaction mentioned is quinidine. If used, it can actually increase the blood levels of digoxin, potentially leading to digoxin toxicity if the digoxin dose isn't reduced.
So using those two together requires careful dose adjustment. Lots to keep track of for the vet team.
Definitely, it requires careful selection and monitoring.
Which brings us to follow-up. Once treatment starts, how are these pets monitored? You mentioned the Holter.
Yes, monitoring is critical. Checking the heart rate frequently is important, both at the clinic and ideally by the owner at home, counting the resting heart rate. ECGs are needed to assess the rhythm, but as we discussed, a spot check heart rate in the clinic can be misleading due to stress or excitement.
The white coat effect.
Exactly. So the Holter monitor really provides a much more accurate picture of the heart rate control over a full day during rest, sleep, and normal activity. It's invaluable for assessing if the rate control medication is working effectively and if adjustments are needed.
So Holter is really the gold standard for checking treatment success. What about potential complications of having AFib or flutter itself?
The main complication really stems from the arrhythmias effect on heart function. The onset of AFib or flutter can definitely lead to a worsening of cardiac function, potentially tipping a previously compensated animal into congestive heart failure.
So it can push him over the edge, functionally.
It certainly can. Yeah.
Okay. And finally, bringing it all together, what's the overall outlook, the expected course and prognosis for pets with these conditions?
It really depends heavily on that primary versus secondary distinction. For secondary atrial fibrillation or flutter, the common type linked to significant underlying heart disease, the prognosis is generally considered guarded to poor. It reflects the severity of the heart condition that allowed the arrhythmia to develop in the first place.
So the outlook is more about the underlying disease in those cases.
Pretty much, yes. The arrhythmia is often a marker of advanced disease. However, for primary atrial fibrillation, those typically large dogs with structurally normal hearts on ultrasound, the prognosis is often quite good, especially if the heart rate can be well controlled. They can often live a good quality life for a long time.
That's a huge difference. So the ultrasound findings are really key for prognosis. Okay, wow, we've covered a lot of ground there. Let's try to quickly boil it down.
Yeah, a lot to digest.
We've talked about atrial fibrillation, that chaotic, irregular rhythm, and atrial flutter, which is often faster but more organized with those sawtooth waves.
Right. And the crucial difference between primary AFib, mostly in big dogs with okay hearts, and secondary AFib or flutter, which signals underlying heart trouble.
And diagnosis relies heavily on the ECG, listening for those tennis shoes in a dryer, and imaging, plus the Holter monitor to see if it's constant or intermittent.
And treatment often focuses on rate control for secondary cases using drugs like digoxin, beta blockers, or diltiazem, while conversion might be considered cautiously for some primary cases.
I think, for me, one of the big aha moments was that huge difference in prognosis between primary and secondary. It really underscores how important it is to know why the arrhythmia is happening.
Absolutely. And yeah, that tennis shoes in a dryer sound, while alarming, is such a memorable way to describe that specific kind of cardiac chaos. It sticks with you.
It really does. You know, diving into this makes you think about the complexity of the heart, this electrical and muscular marvel, and seeing how different the outcomes can be based on the underlying structure. It really highlights the interconnectedness of it all in our pets. It kind of leaves you wondering, doesn't it? Thinking about these different causes, the challenges in treatment, especially in converting back to a normal rhythm.
Yeah.
What might the future hold? Are we likely to see more targeted therapies or maybe even better ways to prevent these arrhythmias from developing in susceptible animals?
That's the hope, isn't it? Continued research into the fundamental mechanisms, better diagnostics, maybe even genetic insights down the line. It's all about improving our ability to manage these complex conditions and give these animals the best possible quality of life, a really important area in veterinary cardiology.